So now let's go on with a particularly super high yield concept, which are the cardiac glycosides. We're going to hit the section with some of the drugs used in treating heart failure. The first group we will talk about is digoxin. You may have heard this also called digitalis, because it is derived from the plant named Digitalis purpurea. If you can remember the different transporters on this cardiomyocyte on your screen and which one digoxin blocks, that's all you need to know. You can reason through the different ways that digoxin can help improve the intrinsic contractility of the heart, and you can also understand how some of the side effects manifest due to the inhibition of the normal function of these pumps right here, these three arrows. You remember these? You will know how digoxin works and the side effects. So digoxin inhibits the extracellular component of the ATPase so that it is directly inhibiting potassium from binding this location. It is competing like a competitive antagonist. By doing so, we decrease the functionality of this pump and decrease the outward flow and inward flow of these two ions. Therefore, we create a low intracellular potassium concentration and a low extracellular sodium concentration. Well, what does it do for this sodium-calcium exchanger also on the myocyte membrane? You essentially just deprive this sodium-calcium pump chilling on the membrane from having an adequate driving gradient or adequate fuel source. And by fuel, I mean the driving force of high extracellular sodium to use for pumping calcium out of the cell. You need the sodium to pump in while calcium can be pumped out. The result is that we eventually just accumulate a bunch of intracellular sodium and intracellular calcium because we've abolished this gradient. We normally have very high extracellular sodium concentrations. The end result is that we have an increased intracellular concentration of calcium, which leads to increased binding to troponin C and liberation of the myosin binding sites on actin so that we get more actin-myosin interactions. We have repeated this, that this increase in actin-myosin interactions equals an increase in contractility, or inotropy. Sounds like an ideal drug for someone with systolic dysfunction, right? Because we want increased contractility. You bet it is. This is not the only mechanism of action of this drug, though. It is not yet completely understood how digoxin increases parasympathetic tone to the heart. It increases parasympathetic activity on the AV node, and that is the reason why the AV node will have an increased refractoriness or inability to be restimulated when this drug is given. This is why you can give the drug to people with supraventricular tachycardias, or tachycardias that are above the ventricles, because you want to decrease the ability of the AV node to conduct every impulse. Supraventricular tachycardias are particularly dangerous if they stimulate the ventricles at a 1-to-1 rate. So you can give something that delays conduction through the AV node to make it a 2-to-1 rate, where the two impulses above the ventricles are only conducted as one impulse. What am I talking about? Well, if you have atrial fibrillation, your atria are going wild contracting. If the AV node conducts every single one of these depolarizations every single time, then the ventricles are stimulated and they will be contracting at the incredibly high rate, which basically eliminates the diastolic time for diastolic filling, and then you'll be shooting blanks out of your left and right ventricles. So get ready for this. Guess what USMLE examiners are going to go after you with? Mechanism and toxicity of digoxin. It will be on your exam. You need to know it. They particularly love digoxin because it tests your knowledge of myocyte physiology that would be expected in a normal condition, and then it tests you on what goes wrong. A great way to save a patient's life is to understand how digoxin toxicity presents and how to treat it. Believe it or not, I've seen a patient that just decided to take way too much digoxin. The same way digoxin can be beneficial by inhibiting the sodium-potassium ATPase can also kill your patient if there's excess inhibition. Remember, digoxin is like a competitive antagonist. The more digoxin you put in here, the more it's going to be able to compete with this potassium binding site. If we're inhibiting the sodium-potassium ATPase, what do you think is going to happen to the intracellular sodium concentration? It's going to go super high because we can't pump that sodium out of there. What do you think is going to happen to the extracellular potassium concentration? It's going to go super high because it has to compete with digoxin and get pumped back into the cell. So I denotes intracellular and E denotes extracellular. So we end up keeping the sodium inside the cell and the potassium out. This gives us an overall net positive charge on the inside of the cell because we keep 3 sodiums in and 2 potassiums out. Normally we throw out one more positive because we're pumping out 3 sodiums versus bringing in 2 potassium. So now we've shifted our transmembrane potential towards a more positive value because sodium cannot just leak out of the membrane like potassium can. So we have a much more positive environment inside the cell because sodium cannot leak out. Now we're closer to depolarization threshold. So this is why accumulating a bunch of positive potassium ions on the outside of the cell and even more sodium ions inside the cell a really, really bad situation. So number 1, accumulation of potassium on the outside of the cell can lead to some severe side effects related to hyperkalemia. We have way too much potassium in the blood. Hyperkalemia can present with a decreased QT interval, ST scooping, and T-wave inversions. It says in your first aid book that when you have hyperkalemia, you should be thinking about a poor prognosis. Well, if we have hyperkalemia, why is this a bad prognosis? It means that we have severely distorted the normal intra and extracellular concentrations of sodium and potassium. It means that we have a lot of digoxin going on because we've gotten to the point where we've depleted the intracellular potassium and made the extracellular potassium really high by preventing the intracellular component from being restored by the ATPase pump. If we're going to restore this gradient in someone that is already having severe heart problems, it is going to be particularly tricky. So what about the accumulation of sodium inside the cell? Again, we raise the transmembrane potential to a more positive value because we're keeping 3 positive ions in while only allowing 2 to remain on the outside. Normally it's different, and then even potassium can leak across the cell and further get rid of another positive charge, leaving only negatively charged intracellular proteins, causing a very negative transmembrane potential. So let's say that if I have some cells in one area of the myocardium that are more affected than the others, they can be able to conduct at completely different times. Because some cells are going to be able to depolarize sooner than others, we have the perfect environment for re-entrant loops of electrical depolarizations to occur. So this area of the heart will be ready to depolarize while this one is still repolarizing. You can create a loop where there's just a constant electrical depolarization within the ventricles. The fancy word for these are re-entrant ventricular arrhythmias. So another toxicity related to the inhibition of the sodium-potassium ATPase is the accumulation of intracellular calcium. It may be great initially, but if you continue to accumulate intracellular calcium, you will eventually open some calcium-dependent potassium channels located on the myocyte membrane. This causes you to have a quick efflux of potassium that increases the rate at which you repolarize. Remember, we said that depolarizing too fast or too slow is also a bad thing. It disrupts the normal synchronizing repolarization of all channels, so that they not only fire too quickly, but they can get out of sync, and one area of the ventricle can repolarize or depolarize much faster than the other one. The myocardial cells should always work as a team. So this accumulation of intracellular calcium can also trigger depolarizations because the phase 2 of our myocyte depolarization is dependent on the influx of calcium and the efflux of potassium. If this really high accumulation of calcium within the cell can open some of these potassium channels, then we repolarize much faster than we initially wanted. If you already have a sufficient amount of intracellular calcium, then you're going to be ready to pull that trigger on the next depolarization because you've pushed out that potassium by opening those potassium channels, and you're going to cause a depolarization that occurs way too early, which is an early after depolarization. So now let's talk about some of the other toxicities related to this very high yield drug. Anytime you mess around with the conductivity of the AV node, you predispose yourself for depressing that AV node all the way to the point where you get a complete block. No conductivity, that's really bad. This should make sense to you because we are actively depressing the conduction through the AV node. It is not understood why with digoxin. Some of the more difficult to understand toxicities with this drug, and therefore the more high yield ones, are due to the effect of digoxin when it can enter the cerebrospinal fluid. So can you tell me which area of the brain is going to stimulate nausea, vomiting, and decrease appetite if digoxin binds it? That would be the area post-REMA. This was actually an answer on 2 of my step 1 exam questions. So we discussed some toxicities what are some things that we can watch out for so that our patient won't reach toxic digoxin serum levels? Number one, digoxin is excreted by the kidneys. It also competes with potassium for the binding site of potassium on this pump, and it binds albumin with a 20 to 40% distribution. With these in mind, you should adjust your doses for someone that has terrible kidneys, they're in renal failure, they can't clear digoxin. You need to be careful in hypokalemic patients because they have very low levels of potassium to compete with digoxin for this binding site here. And avoid giving it to patients that are already taking other drugs such as verapamil, amiodarone, and quinidine because they can actually directly displace the digoxin from the albumin, therefore liberating the amount of free digoxin. So what about the famous blurry vision, often referred to as the Van Gogh effect? This sounds like an excellent time for us to review how rods and cones work. Let's go through this really quickly. So remember, light is a photon, hits the cone, which has rhodopsin, and causes a conformational change in the rhodopsin molecule, which is bound to a stimulatory GS protein, which becomes activated to induce the production of more cyclic GMP phosphodiesterase. So it increases the activity of the enzyme that breaks down cyclic GMP, which is the phosphodiesterase. We have a decreased activity of cyclic GMP within the cell because we induced its enzyme. Without any cyclic GMP, we close the cyclic GMP gated ion channels and reduce the influx of potassium via those channels. And this is all occurring in the eye. So basically, we are manipulating the signaling within a cone, causing an accumulation of potassium on the outside, which causes hyperpolarization because we're accumulating a positive concentration of ions on the outside. So if we have a bunch of digoxin floating around, it can inhibit the sodium potassium ATPase that is on these cone cells by disrupting the normal potassium ion concentration. We will disturb the signaling of these cone cells responsible for the generation of action potentials that will tell our brain what colors we are seeing. These are always depolarizing. When you hyperpolarize the cell is when you actually get the perception of color. But we are manipulating this very tight potassium concentration with digoxin just floating around. And that can lead to abnormal color perceptions, such as the perception that you're seeing like Van Gogh, the blurry yellow vision. So vignette time, because I wouldn't spend this much on digoxin if it wasn't that high yield. You better believe digoxin will show up on your step 1 exam one way or the other, whether it's knowing myocyte physiology, knowing the side effects. So you have a 67-year-old heart failure patient on multiple medications coming to your clinic with a heart rate of 55, blood pressure of 100/60, and a 3-day history of nausea, vomiting, diarrhea, and a decrease in her vision. You admit her to the hospital immediately, concerned that she has taken an excessive dose of one of her medications. The EKG performed on admission shows signs of hyperkalemia. You probably won't see an EKG. This might be one of the rare occasions where you get a classic descripting buzzword such as inverted T waves on the EKG in your vignette. Or if you do get an EKG, it will be something strikingly obvious like crazy ST changes. The question will be, what is the next step? So if you do get an EKG, it will be something obvious like very prominent ST changes. What is the next step will probably be something that you will see. This kind of sounds like a step 2 question, not a step 1 question. But any questions related to toxicities and how not to kill somebody are fair game for step 1. You don't even need to know what the next step would really be. Just think about the fundamentals that you know about digoxin. So lots of things should be pointing towards digoxin toxicity, besides that we just finished discussing it. So we have a heart failure patient, so she's probably taking something that can help with their contractility, such as digoxin. And we suspect this because she has a lot of the manifestations of digoxin toxicity, which is nausea, vomiting, diarrhea, vision problems, ST changes, most likely related to hyperkalemia because digoxin inhibits the sodium potassium ATPase by competing with the extracellular binding site for potassium. So we can come to the conclusion she's probably hyperkalemic. due to the ST changes, we said that was a really bad prognosis. So the next step should be to make sure that we stabilize her myocardium with some magnesium sulfate, set her up for a cardiac pacer if she needs it, and give antibodies that will directly bind the digoxin to help clear digoxin from her system. We stabilize her myocardium with magnesium sulfate because it helps stabilize the membrane by directly competing with calcium channels. They're divalent cations, so they both have a 2+ charge and they both can sit in the same channel, and that's why you give the magnesium sulfate. Alright, let's do a quick flash quiz just to reinforce a little more digoxin knowledge. Digoxin is removed from the body by blank excretion. This is a straight, simple question. Remember, we discussed how you need to be careful about the administration of digoxin with renal failure patients because it is cleared by the kidneys. So it is cleared by the urinary system, aka the kidneys. So renal failure can lead to digoxin toxicity, not because they took too much, just because they cannot clear it out of their system. This is something super important you must remember. Never answer digoxin in a patient that presents with a bunch of risk factors for renal disease, such as diabetes mellitus, hypertension, or chronic NSAID use for someone that has like rheumatoid arthritis or osteoarthritis, and then they'll sneak in a laboratory value on the side, such as an elevated creatinine. And that's how they like to ask you about the metabolism of digoxin. They'll give you a patient that has risk factors for renal insufficiency, show you a value that reaffirms your suspicion that they might have that, and then they give you some signs of digoxin toxicity, or potentially ask you why this patient should not start any sort of digoxin therapy.